Hello, my hand is up. Hello, group 2.
Hello.
Yes.
Sister, please, we are trying to share our screen, please.
Okay, we are waiting.
Hello, please. Please, can you see my screen?
Yes, please.
Yes, please.
Yes, please.
Okay.
Yes, please.
Yes, please. Good evening once again, colleagues.
Good evening,
Good evening.
Good evening.
We are presenting on abdominal examination. Our objectives
Please, your
at the
name.
end of, and please, I'm Gifty Kwabi. And please, our objectives at the end of the presentation, you'll be able to know what abdominal examination is, purpose and indication of abdominal examination, 3, preparation for abdominal examination, and then 4, requirements for abdominal examination.
Please, I'm Teresa Nancy Opon. Abdominal examination. This is one of the most important physical examinations carried out during pregnancy. Abdominal examination is done to determine the gestation, positioning, line, presentation, and also to affirm that the fetal growth is inconsistent with the gestational age. It also aids in proper management of labor. So please, with this, when as midwives, when we do abdominal examination, it will help us more to know what is the fetus is presenting, the position, the lie, and also how to manage labor properly. Please, the next person.
Hello, please, I'm Anastasia Dumakwapia. Hello, sisters.
We can hear you.
Continue.
Hi, we are with you.
Please, can you hear me?
Yes, we can hear you. Go on.
Oh, okay. Please, there are 3 senses involved in abdominal examination, and these are visual inspection. Here we are going to inspect the shape of the abdomen, the size in relation to the gestational age, and we check if there is any skin changes like linear nigra and strigovidarium. And then we check whether there are previous obstetric scars, or previous CS. Then we check if there is any fetal movement. Then we come to tactile palpation. Here we are going to, the palpation involves in 3 types, and they are fundal palpation, lateral palpation, and pelvic palpation. When we come to lie, you check for whether the baby is in transverse position, oblique, or longitudinal. And you check for the position of the baby, whether the baby is in occipital anterior or occipital posterior. Then we move on to the auditory. Here, with the help of the lateral palpation, we will be able to locate the back of the fetus so that we can auscultate. Thank you.
Sisters, please, the next person should continue.
Please, the next person.
Please, sisters, good evening.
Good evening, please.
Please, I'm Paulina Gary. I'm presenting on the purpose of abdominal. People to observe the signs of pregnancy. 2. To assess the fetal growth and size. 3. To assess fetal heart. 4.
Nana, me show me the mama do I. Now a 10 and can say no. Nana,
Hey, sister.
Please, can I continue?
Nana, put the
Please continue. Continue.
Mamma, I mean, no, they are going
Diagnose the fetal part.
Please, then
No, sister, please continue. Oh.
Please, with the purpose of abdominal examination. 1. To observe for signs of pregnancy. 2. To assess fetal growth and size. 3. To assess fetal health. 4. To locate and diagnose fetal parts. 5. To detect any deviation from normal. So when abdominal examination is done, these are things that will.
Please, are you done? Stop, Felicia. Stop, Paulina.
My network
We are
was bad.
waiting.
Paulina. Hello, Paulina.
Yes, madam. Please,
Your background is full of noise.
Please.
Paulina.
Yes, madam.
Your background is full of noise. It's making it so uncomfortable for us to hear.
Okay. I've moved out of that place. Please,
Okay.
I'm presenting on the abdominal examination. So as part of this in preparation, the midwife needs to review the client's antenatal card. As my sister last said, so when you check the antenatal card, you see like
Paulina.
Yes, please.
Please, you are not the one presenting on preparation. You were on purpose.
Okay. I thought I heard someone.
I'm presenting on preparation for abdominal examination.
So check up and then finish it.
Hello.
Please, good evening, sisters.
Your name?
Please, I'm Atia Seidu Sakina, and I'm presenting on preparation for abdominal examination. Okay, before you conduct an abdominal examination, you first of all has to establish rapport with the client. You introduce yourself to the client. You make the client comfortable by what? Giving an active listening and open communication with the client. After that, you then have to explain procedure to the client. You let the client know what you are coming to do on her before you proceed with the procedure. So in that case, you make the client comfortable, make her relax before you now proceed with the procedure. Before that, so you have to also ask for her consent. You ask her for her to consent before you do the procedure. When she doesn't agree, you cannot proceed. So by asking for her consent, you let her understand that this procedure is part of your routine procedures. So you conduct it for every pregnant woman who comes to your facility. So when she agrees that you conduct the procedure on her, that is where the midwife will now prepare herself. So now, as part of the preparation, the midwife needs to review the client's antenatal card. Yes, that is, you review, you check for her past and present obstetric history. You check whether
But Oba no I think what do you coin?
she has
Hey,
done all
it's
the
basketball.
and then you check for her
Hey,
gravity, her parity. You check for all the sensitive information you need to know and to attend to. Then you ask her to empty her bladder, because before you conduct the procedure, you need to let her empty her bladder so that you can get an accurate findings or results. Then you help the woman to lie comfortably on the couch with the arms by her side and also relax her abdominal muscles. So when that is done, you then provide privacy. So the privacy, you either draw your curtains down or you bring close your screen, whichever one is available. So this will let the client know that whatever you are going to have or conduct on her is going to remain within or in between you and her only, but no third person is going to be involved. So in that case, client will feel relaxed and have that trust in you. So she'll give you all the maximum cooperation for you to carry out the procedure. Then you undress her to expose the abdomen, because it's only the abdomen you are going to work on. You don't have to undress her completely. In some cases, some of the clients, they do come with their cloths to the facility. So if she comes with a cloth and what she's wearing, when she exposes her abdomen, her limbs will be exposed. Then you use a cloth to cover from the legs to the waist side, and then exposing only the abdomen. That is where you're going to work on. If she doesn't come with such tool and you need to drape her, you do that so that she'll have that trust.
Please increase the font size for us, okay?
Pardon?
Please increase the font size for us.
Okay. Okay. Then you wash your hands with soap and water. You dry and warm your hands before you start the procedure. Hey. Is it okay?
Please reduce it. Let her zoom it herself.
I think it's okay now.
It's okay.
So you wash hands with soap, water, dry and warm before starting the procedure. Yes, this is done to reduce transfer of infection and all that. And then you don't just wash your hand and then start the procedure. You have to dry it up and then warm it so that you now start the procedure. So before you start the procedure, you stand by the right hand side of the client. That is the position you the midwife has to position yourself before you carry out the procedure. Thank you. Please, someone can take from the inspection.
Who is taking it up?
Please, I'm Teresa Nancy-Okon. I'm doing the inspection. With the inspection, this is done to determine the shape, the size, the scars, skin changes, fetal movements, and contours of the abdomen. So, as a midwife, when you are doing inspection on the abdomen, you have to notify these signs, the shape of the abdomen, that if there are previous scars, skin changes, and also fetal movements. Then please, we are going on with the palpation. The uterus is palpated.
The inspection, did you mention your name?
Yes, please. Teresa Nancy-Okon.
Selina.
Teresa Nancy-Okon.
Okay.
Please, with the palpation, the uterus is palpated through the abdominal wall to determine the following: fundal height, so as to compare with the period of gestation, the lie of the fetus, the presentation, the position, degree of engagement, to diagnose other complications like multiple pregnancies, fibroids, abdominal pregnancy. So when we do the palpation, it will help us to know the fundal height and the gestational age, how the fetus is, the lie of the fetus, what the fetus is presented, the positioning, and to know that for the engagement. And in the palpation, we have 3 types. We have the fundal palpation, we have the lateral palpation, and the pelvic palpation. So with the fundal palpation, symphysiofundal height is indirect. So with the symphysiofundal height, the 0 mark of the tape measure is placed on the upper border of the symphysis pubis. Upper border of the symphysis pubis. The superior edge of the patient pubic hair must not be confused for the superior border of the symphysis pubis. The symphysis pubis must be palpated in order to locate the superior border. The measurement is taken and recorded in centimeters.
Okay, Teresa.
Yes, ma'am. So please, with the fundal height, you use the tape measure to measure from the top of the symphysis pubis to the highest point of the uterus fundus. And the measurements should be in centimeters. So when this is done, it will help you to know, maybe you get the client is in 36-week gestation, then you do your symphysiofundal height and you are getting 26. It will prompt you that something is happening. It doesn't correspond. So when you do the symphysiofundal height, it will help you to correct any abnormalities for the labor to become normal. Please, that's my explanation.
Okay, Teresa, in your write-up, you've mentioned that multiple pregnancy is an abnormality. It's part of the abnormalities that. How do you clarify this?
Please,
Diagnose complications.
Please, with the multiple gestation, when you are palpating during the lateral palpation, and you are palpating with it, you know that there is one fetus here. When you do the palpation, you also know that the other fetus too is here. And when you do the pelvis, you know the presenting parts. for the first twin. Then you see the second twin when you do proper palpation. So with the abdominal palpation will help you. When you don't do it well, you will not know that the woman is having a twin gestation. And the antenatal part too that he came into will help you with the scan.
So multiple pregnancies is an abnormality that has to be diagnosed. That's my point. My point is multiple pregnancy.
Not an abnormality. No. It will help you, the midwife, to know. So it will help you to know when you are doing the auscultation. You not do only one.
Then maybe you have to change the write-up over there because you've written that to diagnose other complications like multiple pregnancies, fibroids, and abdominal pregnancy.
Please, we have to change it because with the multiple pregnancy, when you are doing the abdominal examination, it will help you during the auscultation so that you not only auscultate for one fetus, you auscultate for two fetus.
So please, if you are talking about complications, you have to delete that of the multiple pregnancy in addition.
Thank you.
Because there are others like, as for the fibroids, it could be intramural or extra. So with that one, it's a complication which you can easily identify. But with multiple pregnancy, I don't think that it is a complication.
Thank you, ma'am. Yes, it's not.
Okay.
Thank you very much.
Are you done?
Yes, I'm done with the fundal height. So someone who is going to take the fundal palpation. Yes, please.
Hello.
All right.
Please, I'm Ampofra Jessica. I'll be presenting on the fundal palpation.
Ampofra?
Yes, sister.
Okay.
So with the fundal palpation, the midwife palpates the fundus in order to determine whether it contains the breech or the head, as the information helps to diagnose the lie and the presentation of the fetus. So with the fundal palpation, our aim is to diagnose the lie and presentation of the fetus. The midwife faces the woman and watches her reaction to the procedure. With the fundal palpation, as you are doing it, you'll be checking the woman to see if there is any discomfort or any pain. The fingers are held close together and curled around the upper border of the uterus. Gentle but deliberate pressure is applied using the palm surface of the fingers. Bridge. The buttocks feel soft in consistency with indefinite or outline. Sometimes the buttocks feel firm, but they are not and well defined like the head. With the head, it feels like a hard, round, smooth mass, which is palatable because the head is separated from the body of the neck. So we move on to the fundal grip. With the fundal grip, both hands are placed over the fundus, and the contents of the fundus are determined. A hard, smooth, round pole indicates a fetal head. So as you are doing the palpation, when you locate a hard and smooth round pole, it indicates that this is the fetal head. Broad, soft, and irregular mass suggests of breech. So as you're doing it, if you locate the part is a part that is broad, that is soft and irregular, it is showing that it is breech. In transverse lie, no parts are palpated. So with the transverse, you are not going to find any line. Please, I'm done.
Please, sister, so he's taking the next one. Continue.
We arrange it.
Lateral palpation.
Your name?
Please, my name is Owusi Manela Adoma. Lateral palpation. Aim: to locate the back in order to determine the position. Method: still facing the woman, the palms of the hands are placed on either side of the uterus at the level of the umbilicus. Gentle pressure is applied with alternate hands by placing one hand on one side of the abdomen to steady it, whilst the other hand gently palpates down the abdomen using a rotary movement to locate the back. Note that the back feels like a continuous smooth resistant object from the bridge down to the neck. And please, for the lateral palpation, you will still stand at the right hand side of the woman.
Okay.
Thank
you. Sister Nancy Patriot was why?
Please, then we are on the pelvic palpation. So please, my name is Teresa Nansiopon. With the pelvic palpation, the aim to diagnose the presentation of the fetus from the 28th week, the position from the 28th week, the engagement of the fetal head from the 36th week. Then for the disproportion between the head and the pelvis. So please, we are coming under the method of the pelvic preparation. The midwife now stands with the thighs against the couch and faces the woman's feet. Whilst carrying out this procedure, the midwife should tend to watch the mother's facial expression for discomfort. The side of the uterus just below the umbilical level are grabbed without causing a discomfort between the palms of the hands. The fingers are held together, pointing towards and inward. So please, with the pelvic palpation, when you are doing it, first you let the woman flex the knee first. Please, with the pelvic palpation, you let the woman flex the knee, because it will help you to know what is presenting proper. Then you also look at the woman's facial expression. Maybe you are hurting the woman. And also, the pelvic palpation too, you have to also know the gestational age of the woman. Maybe she's in 28 weeks of gestation, and please, she's presenting with the bottles. It's not too alarming, but when the woman is at 36 weeks and he's presenting with the bottles, it's alarming because at 36 weeks, the bottles cannot turn for cephalic to come to the presenting part. So when we do the pelvic palpation, it will help us to monitor our labor very well. So please, that's my experience.
Good evening, sirs. Please, my name is Gloria J, and I'm taking it from auscultation. Auscultation is an important part of abdominal examination in pregnancy, which is primarily done to assess the fetal heart rate. It is mostly heard from 20 weeks upwards. Auscultation is listening to the fetal heart sound with the aid of a fetal stethoscope. Auscultation is done to confirm fetal viability and assess fetal well-being as well. Fetal heart sound is best heard over the fetal back, depending on the lie and presentation. So this is how fetal auscultation scope is placed on the mother's abdomen at the right angle over the fetal back. The ear is then placed in a close and firm contact with the fetal stethoscope, but the hand should not touch the fetal stethoscope while listening, as an extra sound will be produced. So this is why, as a midwife, when you are checking the fetal heart rate, you should make sure that you, first of all, as they already said, you provide your privacy and all the other things. When you are done with the palpation, the next thing is for you to auscultate. So already the woman's abdomen is exposed already. So without I'm continuing.
Lawrence, your network.
Abdomen has been exposed already. So you then stethoscope, fetal stethoscope on the mother's. Hello, please, is it okay? Hello, hello, hello.
Hello.
It's okay.
So I was saying that you would have to stand at the right hand side of the mother or of the woman, and you place the stethoscope at an right angle over the fetal back. Then you make sure your ear is very close and firm in contact with the fetal stethoscope. But your hand shouldn't touch the fetal stethoscope, because while listening, you can feel or you can listen to extra sound, which is not, which you can get a wrong answer or a wrong hearing. Please, I don't know if it's clear. So the fetal stethoscope should be moved around at a maximum point. Sorry, the fetal stethoscope is moved around until the point of maximum intensity is located, where the fetal heart sound is heard mostly clearly. The fetal heart sound is then counted for 1 full minute. Normal fetal heart rate is 110 to 160 per minute. Thank you.
Okay.
Good evening, sisters. I'm Aprikwa Abigail, presenting on the requirements for an abdominal examination. We all know that we can't just get up and perform an abdominal examination. We need some requirements down. And first, we need the environment. The environment has to be quiet, comfortable, and there has to be a bed with a bed sheet and a Macintosh with a sterile sheet, and then a screen for privacy. Then with the patient, we will have to seek the patient's consent and be able to cooperate with the patient. And then the patient has to be positioned in the supine position with its knees flexed or bent, slightly bent. And then the patient has to be comfortable and relaxed for you to be able to perform the examination on her. And then we have to expose the patient's abdomen. Then we go to the equipment. The equipment, we need a fetal stethoscope, a measuring tape, and a good source of light. Then we go to the examiner, the person performing the examination. You have to wash your hands. Your hands has to be clean and warm. And you have to have a short fingernails. Thank you.
Okay, I'm Cynthia Adoya. So we are saying summary. In summary, when conducting abdominal examination, you first of all establish rapport and explain procedure to the client. Then you ask the client to empty her bladder. Then you provide privacy. That's by closing your doors and drawing your curtains. Then you wash, dry, and warm your hands. Then you assist client to undress and wear gown. You put the client in the dorsal position. Then you stand on the right-hand side of the client. Then you expose only the abdomen. Then you perform inspection and you measure symphysiofundal height. You perform fundal palpation. You perform lateral palpation. Then you instruct client to bend her knees slightly and breathe slowly through her mouth. Then you perform pelvic palpation and assess her descent. You listen to your fetal heart for 1 minute. You assist the client out of the bed to rest. Then you communicate your findings to the client. You thank client, wash and dry your hands. You record and report your findings. Thank you.
Okay. My
Please, we are done.
question is hello.
Hello,
Hi.
sister.
Sister.
Thank you for your presentation. I want to ask a question or two. Why is it needful for the woman to bend the knees and then breathe through the mouth? What is the rationale behind doing that?
Please, madam, I'm Teresa Lankefond. It will help you to what is presenting. The presenting part will. That's
You said it will help us to
determine what is presenting. The presenting part.
the presenting part.
Yes, madam.
Okay. Any other points over there?
Hello, this is Juliet. It also helps the client to feel comfortable, and then also relax.
Okay.
Hello, madam. The
Yes,
other
sister.
point, when you flex her knees, you get access to the pelvis way so that you can enter and see the descent of the filter head. And it is uncomfortable. So when the mother bleeds through her mouth, it reduces the pains and the pressure so that he will be comfortable when lying. I'm very connected.
Okay, I'm Cynthia. It will reduce discomfort. It will also improve access for the examination. Then the breathing through the mouth, it will promote relaxation.
Sister,
And it will
please.
Hello?
Okay.
And then with the breathing through the mouth, it will reduce pain perception. And it will make the woman comfortable.
Thank you very much for that clarification. Yeah, it actually gives the woman, it helps her to relax in the first place. And then it's also, once she relaxes, you cooperate for that short time you are examining her so that you can easily assess what is down there. But with the abdominal examination, I didn't see the descent. I don't think you mentioned, did you?
Please, we did.
You did mention the descent.
Yes, please.
And you said that this one is what?
Okay.
Hello.
Hello, Mama.
Hi.
Good evening.
Please, we said.
Yeah.
Hello.
We said, I'm Cynthia.
Yes.
So the descent, we said the descent means like how far the fetal head has moved down into the pelvis. So, and it can be assessed in either through the abdominal palpation or vagina examination. Vaginal examination.
Vaginal examination. So with the abdominal examination, assessing the descent, how would you do that? Physically, how would you?
So you ask the woman to lie in the spine position.
No.
So you ask the woman to lie in the spine position with the knees slightly flexed.
Yeah, it's slightly flexed. But what is the duty of the midwife?
The duty of the midwife.
Hello, sister.
The duty of the midwife is to
You
the anterior shoulder of the fetus. Yes. locating the anterior shoulder, it will help you to know how far your left hand, the left finger will locate the anterior finger. Then use your right hand side, you locate the symphysis pubic. Then use your right fingers to measure from the symphysis pubic to the anterior shoulder. If it is 4 fingers, then you know that it is 4 feet. If it is 5 fingers, then you know that the fetal head has descended for 5/5 or 3/5 in order. You know how the fetal head has descended into the pelvic. Thank you.
Okay. So with a descent issue, sometimes it's a problem with even the practicing midwives together with the students who needs help at the facility. That's why I kept asking that question. So you know that the fetal head is descending from somewhere to somewhere. So definitely, when do we even assess the descent? When can we?
When the woman is in labor.
Yeah.
When the woman
Hello,
comes
Mama.
in labor, between the 9 and 36 weeks.
From
Hello.
The pregnancy is up to 36 weeks.
up to 36 weeks.
Yes, please.
Okay. So if up to 36 weeks,
When the fetus has descended
what will
into
be
the
the
bed.
descent?
Because
By
5 feet. 5 feet.
take your time. Hello, take your time. By multiparous and then nulliparous. Can we assess both? Can we have the descent being assessed at 36 weeks, or there are varieties?
No, ma.
Be it,
Please, sister.
There are varieties.
yes.
In nulliparous woman, descent can set in after 36 weeks of gestation. In multiparous woman, descent doesn't set in unless the woman is in labor.
In labor, yeah.
Huh. That is the right thing I want to know, because once a woman has not delivered before, you know, it takes time for all the ligaments, the muscles, and all that is related to causing labor to set in to have effect. More importantly, due to the relaxing hormone, which actually works on these things to relax them, and it takes time to go backwards, forwards, and all that. So there is a variety between the nullips and then the multiparous. With the multiparous, when she's 10 and then she enters into labor, descent can easily be accessible. But with the nullips, yes, she will have to walk in slowly before she can we can assess descent. So with the what about fetal heart rate? At which weeks can we identify fetal heart rate?
16.
It varies.
Hello,
Hello?
sister. Hello.
16 weeks.
Yes.
16 weeks.
Hello.
16 weeks. Can you do palpation?
No, Mama.
16 weeks is taking. The clients will only hear
Hello, hello.
in
Hello.
20 weeks.
Please, it's 24 weeks.
24 weeks.
So somebody said 20 weeks. Somebody says 24 weeks.
24.
So what are we taking?
Hello,
20
Mama.
weeks. Yes, it's 20 weeks.
20 weeks.
Not less than. Yes, it's 20 weeks. That is where you can assess the fetal heart. 20 weeks. Because at that time we affirm that this fetus has fully developed. And then if you palpate, yes, you can definitely, even though it will keep changing its position, As for the fetal heart rate, you can still assess it at 20 weeks. Okay, thank you very much.
Hello.
Thank you.
Hello.
Let's
Good
allow
evening.
the next group to come in to do their this. Otherwise, you take all. Okay, thank you very much for giving us this time. Can we have the next group? Is it group 4 ready? CTG or pain management?
Group 3.
Group 3.
Group 3.
And you
Group
are
3 just
doing
sent me their slides.
Pain
I
management.
forwarded it to you.
pain management. Group 3, pain management. Okay. We are ready for you. So let's move on. Group 3.
Sisters, good evening.
Good evening.
Good evening.
How are you?
Good evening.
Please, we are group 3, presenting on pain management.
Okay.
Hello, please, we can't hear.
Please, the person sharing the slide should move to introduction.
Okay.
Are you group 3 or group 4?
Please, group 3.
Okay.
So please, introduction. Pain is a normal experience during pregnancy, labor, and puerperium. So when we talk about pain is an unpleasant sensory or emotional experience associated with acute or potential tissue damage. So all we are trying to say is pain is unpleasant sensory that we experience during pregnancy, labor, and puerperium, since we are managing it during pregnancy, labor, and puerperium. And when we talk about pain management, is the multidisciplinary medical approach designed to diagnose, alleviate, and manage both acute and chronic pain to improve clients' quality of life and functionality. So our aim is to reduce pain, alleviate pain during these stages that occur during pregnancy, labor, and puerperium. As we move forward, we'll get to know what happens through the pregnancy, the labor, and the puerperium. So it says that effective pain management improves comfort, cooperation, and safety. So in the during ANC, labor, and postpartum, the effect of pain enables the client to become more comfortable. The client becomes cooperative and the client becomes safe. So there is a need to manage every pain your client complains of, not just to say that just a normal pain, but you have to see to it that you manage any pain that the client complains of. Midwives play a key role in assessing and revealing pain. So as midwives, we have a key role to play during pregnancy, labor, and postpartum when it comes to the pain our clients feel. So as we move forward through the slides, we are going to know the key roles of a midwife in alleviating pain during labor, pregnancy, and postpartum. Thank you.
Your name, please.
Please, I'm Arabana Latioko. Arabana
Okay.
Latioko.
Okay.
Okay.
Who is taking over?
Please, Sister Ophelia Edubafo. We are talking about the objectives for pain management. And we know that when you talk about objectives, it's the specific goals or the targets of our study. And as pain management in labor, from pregnancy, labor, and puerperium is very essential when it comes to the midwifery and our practicals. So over here, we have three main objectives we are going to look at. And the first one is we are going to identify some common causes that cause pain during pregnancy, labor, and postpartum. We realize that the pain and the pain threshold of every mother is different. They all don't have it the same, and sometimes the causes also differentiate. So in our study, we are going to identify some of the causes of this pain. And also, we will discuss the pain management methods because we know that during pain management, we reduce the pain intensity, we promote comfort and relaxation. How do we do that? Group 3 is going to help us know. And the third one is that we are going to highlight the role of a midwife in pain management. We know that in pregnancy, it's the duty of the midwife to educate the mother on pain so that when she comes into labor, it will not be a new thing and she will be prepared both physically, psychologically, and emotionally. And during the pain, it's the duty of the midwife to try her best to alleviate pain, if not all, at least to minimize the intensity of the pain the woman will go through. And during postpartum too, breastfeeding can cause pain, bonding with the baby. We have to let the mother understand. So these are the three main objectives we are going to talk about in group 3. Thank you, Ophelia Dubofo.
Thank you. Who is coming again?
Hello, madam. Please, I'm Comfort Ejewadomakun, presenting on pain. Yes, please. With the pain management, yes. With the pain management, the back pain, pelvic and ligaments pain, headaches, and leg cramps. Please, with the back pain, we all know that when there is a pregnant woman, it means there is a fetus in the uterus. And then as time goes on, due to the presence of the hormone relaxing, it relaxes most of the ligaments, the muscles, and this makes it makes most of the muscles relax. So with a little exhaustion, the person feels pain and complains about it. Yeah, so please, as time goes on, we'll get to know about how to manage all these pains. But with the back pain, it can't be eradicated totally when a pregnant woman complains about it. We can only manage it until baby is out or until mother is term and delivers her baby. The back pain will be there, but then we can only manage them. Yes, please. And then with the pelvic and ligament pain. Hello.
Yeah.
Hello.
Hear you.
Yes,
Yeah.
please. Yes. With the pelvic and ligament pain. Hey, who is that? Yes, please. We know that it occurs during pregnancy, and it's a common complaint among pregnant women. It happens because yes, this
Hello. Mm-hmm.
Hello, sister.
Yes.
Yeah, I'm in the person
same
of
as a result of the
Abigail.
hormone relaxing and then the muscles. So as the baby grows, causing pain from mouth to ache, it can manifest such as deep and then stabbing or sting. Whenever the pregnant woman stretches herself, she feels a little pain. Yes, please. And then mostly with the ligament pain, the gravid uterus.
What is
Yes,
going
please.
on?
So with the headache is a very serious concern among pregnant women. Because we know that it's a cause of high BP that would end up with eclampsia, preeclampsia, and then into eclampsia, which is fatal. Please, with the headaches, we sometimes have to encourage them to take in a lot of water. They should have enough rest and sleep too as well. Yes, so we have to encourage the pregnant women that whenever they have a slight, even if it's slight, they have to tell us so that we take early action to prevent any other things that may rise. And then please, with the leg cramps, leg cramp is a common complaint during pregnancy in most of our women, our pregnant women. Please, it happens due to the same relaxing hormone because the leg also consists of muscles. So as it's the weight of the gravid uterus, because of the weight, their leg is also carrying it as well. So this also causes them to have discomforts that could result in the leg cramps. So, and then because of that, there is pressure on the blood vessels. That makes it that blood will not be able to flow to and fro. So it causes their legs to feel uncomfortable, leading to the leg cramps. So in this, as time goes on, we'll be also learning about how to alleviate these leg cramps. Yes, please.
Good evening.
Thank you.
Good evening, sister.
Okay.
I'm in the person of Abigail.
Speaking of Mary, if we are watching,
Well,
and I'm
what?
going to,
Abigail Bakwewa,
please, I'm the one
present
taking this.
from management of during
But there are
pregnancy.
two names. Hello.
Yes, sister.
Why you?
Please,
You are confusing us. Two
Sister, I'm
names are
present from
coming.
non-pharmacological. Sister.
Your name?
Abigail Bakwewa. I'm present on management of pain during pregnancy, and I'm here doing non-pharmacological management. And here we have health education and reassurance. You have to educate clients on proper posture and exercise, and adequate sleep and heat or cold application. Education on proper posture. You educate clients to sit straight and support her lower back with small pillows. And also educate her to keep her knees at 90 degrees angles to help the hips to avoid crossing legs. And Also, when the client crosses legs, it prevents proper circulation of blood. And with the adequate rest, you encourage the client to have enough rest to reduce stress and fatigue. And with that, you can also educate her on good sleeping positions. You educate her to sleep on her left lateral position. And also, with the heat or cold application, you educate her to use low to medium heat pad in a towel to place on her back whenever she feels the pain. Thank you, sister.
Okay.
Good evening.
Yes. Good
Please,
evening.
I'm in a person of Midwifery, and I'm here to talk about the pharmacological management during pregnancy. Yes,
You
please.
said what in Mary?
I'm Midwifery. I'm the one supposed to present on non-pharmacological pain management, and the other person presented.
I'm the one presenting on the pharmacological, okay? Thank you. Hello, sister, please, I'm Matilda True.
So why are you confusing us?
I don't know the reason
Let one
why.
another one person.
Sister, please, when we shared it on the platform, we shared it according to the slides, and
right.
everyone was supposed to. So each person's name is attached to where you're supposed to present, and I was supposed to present non-pharmacological. So that was when I was alerting them on me presenting, but the other lady took it. I didn't understand why, so I kept quiet to then present the next one. Maybe she made a mistake.
Please, it's not a mistake.
Because I've made my notes and everything. And that is what is
Mary, I
giving
free
them
your
things.
Hello,
Yes.
Mary.
Yes, please. Yes, please.
Mary, present. Keep quiet and present. Bring out what you have to give us.
Okay, so please, I'm presenting on the non-pharmacological pain management during pregnancy. Please, so with the non-pharmacological, we are having health education and reassurance. We have proper posture and exercise, adequate rest, and heat or cold application. And with the non-pharmacological, we will say that it is the treatment used when pharmacological. Sorry, please, I'm coming. Non-pharmacological methods are preferred first-line approaches during pregnancy because they are safe for both mother and baby. They help relieve common pregnancy-related pains such as back pain, pelvic pain, leg cramps, and headaches without using medications. And we give our first point to be health education and reassurance. This involves informing the pregnant woman about the normal body changes. You know, when when a woman takes in a seed, the bodies start to change in various ways, and some of them are already previous mothers, so they know. But let's say a newly mother or a newly pregnant mother does not understand all those things. So we the midwives will explain all these things to them that may for example, you are likely to gain weight. Your hormones, you face hormonal changes, and even with your ligament, there will be some relaxations. And we will tell them that why certain pains occur, such as back pain from growing uterus or pelvic pain from losing joints. So we, the midwives, are to explain everything like that to them, and we reassure them, which helps reduce anxiety and fear, because some of them, they don't understand why when I wasn't pregnant I wasn't feeling this way, but ever since I became pregnant, I'm experiencing this, I'm experiencing that. Am I going to die? Will I be able to carry my baby to term? Some people cause fear and panic within them, so we assure them, which helps them, which reduce anxiety and fear. When a woman understands that mild to moderate discomfort is common and not dangerous, it lowers stress levels, which can also reduce the perception of pain. We healthcare providers should explain warning signs that require medical attention. That, oh, madam, please, all these things are normal, but when you see that, let's put an example like the back pain. Oh, madam, when you experience the back pain in excessively, like the pain is too much that you can't tolerate, kindly report to the hospital. Although with all those things you have to report, but there are some things, some of them they'll be like "Enye me ya kesi enti me de me nko." But you have to explain it nicely to the person to understand that if you are facing these things, you have to report to the health facility for medical attention. Encourage open communication about symptoms. Some of them are shy. For them to even open their mouth to even introduce themselves to the health provider, it's really let's say something hard for them to do. So you make them very comfortable. You first introduce yourself to them for them to know you better, and in a jovial way you talk to them so that they will feel okay telling you everything concerning them. So
Okay.
and teach coping strategies like relaxation and breathing techniques when they are in pain or something like that. Instead of them, sometimes they'll be shouting and stuff. Rather, you tell them to relax. Then they start to breathe. You breathe in, you breathe out. After doing those things, you see that you'll be okay. They will get to understand. The second point is proper posture and exercise. Good posture reduces strain on the back and pelvic muscles. Proper posture includes standing upright with shoulders back. So you, the midwife, will explain and demonstrate to the mother how to stand upright. Because with them being pregnant, they will assume any position or any posture they like. They will think that is the best thing for them, but which is not. So you teach them standing upright with shoulders back. So you teach that way. Then you tell them avoiding prolonged standing. Some people can stand like as they are cooking, they are standing. Some people will just stand for no reason. So you tell them and explain to them that you, even if you are in the store or at the workshop or something like that, when you stand a little, you sit for you to be comfortable. And you tell them sitting with back well supported. Some people will sit on kitchen stool, which is not helpful. So you can even advise them to sit in plastic chairs which have a back support, or even this office chairs or any chair, or even if they want to sit, they can sit on a wall having their backs relaxed on the back wall. And they should avoid high-heeled shoes, because they wearing the high-heeled shoes, one, they will get tired easily, and it affects their distance to their postures and stuff. And the next one is safe exercises during pregnancy. So we gave some pictures for us to see. So the exercises we will say walking. We will include walking. Prenatal yoga. Some of them, although not everyone can book the yoga sections, but even at home we can go on YouTube. We will download all those things. The exercises they teach there, even at your prenatal school. Some of the hospitals have prenatal school or pregnancy school. When they come, they teach them all those things. They will teach you how to do exercise as a pregnant woman, and pelvic tightening exercises, schedule exercises. When you come for pregnancy school, they teach all those things, and you tell them the benefits they will gain from all these things. Some of them are strengthens muscles that supports the uterus, improves circulation, reduces back pain and muscle cramps, enhances flexibility and overall comfort. Exercises should be moderate and approved by a healthcare provider. You shouldn't, although you can go online and search for exercises to perform, but some of them are so vigorous to the extent that when you, the health worker, when you even see it, you even become shocked that is this an exercise for a pregnant woman? Some are so vigorous. So when you see, you tell them, oh, if you go online and see all those things, you can come. Oh, okay. Oh, sorry.
are there.
Oh, sorry. Thank you for letting me. So please, what I was saying is that you tell the pregnant woman, oh, if you can go online and search for some of the exercises done by a pregnant woman, because they teach some online, and some of the hospitals to have preschool, which the pregnant women, they come, I think every month they will come for preschool. That the health professional takes them through exercises and stuff. So all those exercises are taught at the preschool, and some are online, but some are so vigorous to the extent that the ones they see online, so if they see those things online, they can bring it to the health professional when they are coming for their next visit to show them that, oh madam, please, I saw this exercise online, please, can I practice it? When your healthcare provider approves of it, you can do it. But if your healthcare provider sees that this is too much for a pregnant woman to do, you have to abstain from it. And the next one is adequate rest. Please, with this, rest helps reduce muscle fatigue and stress on joints. Recommendations: sleep on side, preferably left side, for better circulation. You know that when we were in college, we were taught that when the reasons why we tell the pregnant women to sleep on their left instead of their right is that, for when you sleep on the right, the heart hangs, so you see that there will not be proper circulation of blood. But when the pregnant woman sleeps on the left, the heart rests. So with that there is proper distance circulation of blood to the mother and the fetus. That is why it is recommended. So we explain that to the pregnant woman for her to understand why, because some are inquisitive and they will ask you, madam, why is it that always you people tell us to sleep on our left, not our right? So when you explain that to them, they get to understand the rationale behind it. And you tell them to use pillows to support the abdomen and between the knees. So some of them, they will come, those who will come with back pain.
Mary,
Yes, please.
Mary, are you not done? Do you still have a lot?
No, please, just more.
You have others to come in the time.
Please, with the heat or cold application, you tell them to use a warm compress, and that is it. Please, I'm done.
Hey, thank you.
Hello.
Yeah.
Hello.
Hello, sister.
Hello.
Hello, sister.
Hello. Hello. You are on.
Hello.
Hello.
Hi.
Hello.
Hello.
Hi. Those who are here to present, can you please summarize for us? Hey.
Hello.
Hi.
Hello.
Hello.
Hi.
Please, can you hear me?
Yes, we can hear you.
Okay, sister, please.
Yes, please.
I'm Matilda True. I'm presenting on the pharmacological management. If all the above my sister said, if the client goes through all that and the pain is still there, prescribe acetaminophen or paracetamol to the person or to our client. Acetaminophen is generally considered suitable for managing pain in pregnancy. We are advised to prescribe the minimum effective amount for the shortest period of time. Point 2, avoid self-medication. Clients are advised to avoid self-medication. Clients are not supposed to. We should advise clients to not go in for over-the-counter drugs that are not being prescribed, and also herbal concoction, so to prevent serious harm to the mother and the baby. And so to prevent serious harm to the mother and the developing fetus. Some of the harms include risk of birth defects, miscarriages, premature birth, and also problems to the development of the fetus. Thank you.
Thank you.
Hello, madam.
Hello.
Please, my name is Konyu Rejeshi. Please, can you hear me?
You can
Yes,
continue.
we can hear you. Please, my
Yeah,
name is
madam.
Konyu Gertrude,
Can hear
and I'm
you.
presenting on the pain during labor. So the first point, we have uterine contractions. We all know that contractions are rhythmic and painful. The stretching and relaxation of the muscles during labor will cause so much pain for the woman. Normally, when we see a woman in labor who is not contracting, you don't see her behaving any way that shows that she is actually in labor. So when you see a woman contracting, she is really in pain. And you see some of them who don't even talk. You find them talking, saying, I will never deliver again because of the contractions and the uterine contractions, which is one of the cervical dilatation. You know, from the contractions, it is helping the cervix to dilate. The uterus contracts, and then we all know that the cervix is the mouth of the uterus. So as it's relaxing and stretching, it does the same to the cervix. So that's an act of dilation will cause pain to the woman. So we have pressure too. When the presenting parts, all the amniotic fluid and other membranes in the uterus is putting pressure on the woman, or especially in the pelvis, you see that you have backache and all other physiological muscles and ligaments, they all lead to pain for the woman. And then fatigue, we realize that those who come into labor already tired, they feel more pain than those who come in a calm manner, in a calm state. So we should encourage our women to relax before they come into labor so that they don't come tired already to already face what is tiring for them. Then we have anxiety and fear. We should encourage and educate the women on the process of labor. At least let them have an idea of what is going to happen to their body so that when they come into labor, they won't over-exaggerate pain and things. But if we don't educate them, they may take it to another level, and this all will lead to pain. So we have some people too, there are other cultural factors and other physiological factors, as I mentioned, the hormone relaxing, causing and ligaments, leading to pain and all other things. They all add to pain for the woman during labor. Thank you.
Oh, thank you very much.
You're welcome.
Mm-hmm. Group 3, are you done?
No, please.
Hello, madam. Please, I'm presenting on non-pharmaceutical pain relief in labor. We say breathing and relaxation techniques. During labor, the pregnant woman feels much pain. So you encourage the mother to breathe in when there is no pain, and relaxing techniques like rubbing the back, massaging the back for her. The sacral back rather for her, encouraging her not to be shouting or making any moves which is going to make her feel tired or stressed. Positioning and ambulation. Either you position the woman on the left lateral, or you talk to her to walk slowly. When there's contractions, the woman can relax. When there's no contractions, she can walk slowly or stretch her body. Emotional support and encouragement. You can call in any relative around, whether a husband or the mother or a sister, to encourage her, or you yourself can encourage her to that the pain cannot be relieved at all unless the baby has been delivered. So you have to encourage her, reassure her that she's in the safe hands, everything is going to be well. You are going to help her to deliver her baby safely. Thank you.
But encouraging the woman to be walking around is needful. But unless, for example, if the membranes have not ruptured, it should be added to that. Once the membranes rupture and then she walked around, especially sometimes the membranes will rupture, but once they stand out to walk around, you see that the drainage of the liquor would be more. So if the membranes have not ruptured, yes, she can do all that we are saying, walking around and all that. But
Thank
if
you.
the membranes are ruptured, then we should be cautious of how we encourage them to do the walking around. Because some of the women, they can walk briskly around even to the washroom and come. When she gets the pains over there, she will sit on the water closet. By the time you go, the baby has been delivered into the pot. So maybe with that around, we have to be cautious of how we encourage them to do the walking. And I think around all the facilities, I don't know whether the relatives are encouraged to come and support their wives or their relatives over there. The place is simple, small. The space, sorry, the space is small, and then you can find women. Let's say the best around there may be 3 or 4, and if all their relatives are inside there, this one has exposed herself. She wouldn't listen to anything because of the pain, and this man is standing by the wife, or sometimes it's not feasible. We talk about that, but I don't think it's always. Maybe if they have some VIP places, that could be, or we can have some screens to prevent others from seeing what others are doing. That could be well accepted. I don't know what goes on right now at the facilities, but that is my view of seeing that these people are also protected from others from viewing their nakedness and all that. So we should take all that things into consideration. Anyway, thank you. Any other?
Hello. Please, I'm
Hello.
Juliana. Hello, I'm Juliana Badieka. Please, I'm presenting on pharmacological management during labor.
Physical. Did you say physical?
No, pharmacological pain management in labor. Can you hear me?
Pharmacological, somebody has already mentioned that. Or you did that with a person?
No,
yes.
I'm presenting on pain management during labor. They already mentioned during pregnancy, but this one is we are managing pain in labor. Yes, so we are saying that during labor, if all the above mentioned non-pharmacological pain management fail, we have to step in with pharmacological, and some of the pain management regarding pharmacological, mostly at the beginning of labor, we can give acetaminophen, which is acceptable. But as labor progresses, sometimes we can give opioids like Petidine as prescribed, either IV or IM. And we can also give epidural anesthesia where applicable, mostly in the theater. And we can also do local infiltration of the nerve, which is always referred as nerve blocks. Or there are also other pain management like inhaling nitrous gas, mostly 50% of the nitrous oxide and then 50% of oxygen for the woman to inhale, which usually fades off within short minutes or seconds. So these are some of the pharmacological pain management during labor. Thank you.
Labor. Thank you.
Welcome, madam.
Good evening, sister.
Good evening.
Please.
The one who did that. Hello, wait. I didn't get your name. That woman, that lady.
Please, I'm Juliana Badiekanga.
Juliana, okay. Yes.
Good evening, sister.
Good evening.
Please, I'm Irene Krama Asare.
Okay.
And I will be taking you through the role of a midwife during labor, how we manage pains during labor. So we are saying one, continuous pain assessment. With a continuous pain assessment, the midwife assess the pain with two tools. We have technical tools that we can use to assess pain during labor. And one of the tools are the visual analog scale. That we call it VAS, or the MC pain questionnaire. So how to use the visual analog scale? One, you ask the woman to rate her pain level on a 10 centimeters line, with indicating 0 no pain and 10 indicating worst possible pain. So with this, by scoring the woman, you calculate the measuring distance from the left point, that's the 0 to mark made by the woman. That will let you, the midwife, know the severity of the pain of the woman. So that's how we use the VAS to test the pain during labor. Then second, we can use the MCQ pain questionnaire. With this one, we ask the woman to choose a descriptor that's the best describe her pain and rate the intensity of her pain from a scale of 0 to 10. So you ask the woman to choose from 0 to 10 and describe how her pain's scale is from maybe 0 to 10, and the woman will tell you, my pain is from maybe 0 to 5. So that will let you, the midwife, to know how intense the pain is. Then you address it or you act accordingly.
Okay.
So yes, please. Then second point, we provide comfort measures. As a midwife, during labor, we have a duty to play in providing comfort measures for a woman in labor. So with this, the midwife can help the woman cope with pain and release anxiety during labor. This can help the midwives and teach the woman various breathing techniques such as deep breathing exercise, slow breathing exercise, blowing out exercise. It will help the woman to relax her muscles to relieve some of the pain. And secondly, we can reassure the client and physiological during labor, but we reassure the client is in safe hands and you are with her. Three, you can help with massage. This will help the woman release some of the pain and relax the muscles so that the pains will reduce much. And with the sacral massage, it helps them and it helps them to feel comfortable during labor. We can also introduce hydrotherapy for her. You can help the woman get a warm bath or shower to help her relax her muscles. And also, we all know that when clients are in labor, they are much exhausted. They don't feel like eating. So we can help the woman by feeding her so that the woman can get much energy to pass through during labor. So we can help them feeding her when they feel reluctant not to feed. We can go ahead and feed them by ourselves as midwives. Then we can also help them with heat or cold therapy. That one to also help them to relieve some of the pain. We can apply them on their abdomen, sometimes on the waist or you alert the woman to show you where the pain is intensified, and you apply the hot and the cold compression over there. Also helps the woman to relieve some of the muscle pain. Also, we can, and the third point, we said we help the woman support informed choice. The third point, we all know that in labor or in our settings, client has her choice, and we can help them to choose a choice that can help them to deliver safe mother and the baby. So with the informed choice, you can assist the woman to choose a posture that will help them. Because we can't, maybe a client is in labor, you can't tell them to walk when the memories are fractured, as sister said earlier on. So a client might tell you that, sister, please, I want to walk around. But you, the midwife, you know best. And you know that by letting her walking around, and when memories are already ruptured, they can put the mother into danger, both the mother and the baby. So you can help them. They can choose their choice, but you guide them as a midwife, guide them to choose the best position that the clients can assume that will not prone them into danger, both the mother and the baby, such as walking around, and then squatting. All those things can help them relax them from. And also it can distract them by giving them music, playing music with them. That one to also help them. Others too, you can prefer to pray with them. That's to also release them from tension and anxiety. Then point 4, we monitor maternal and fetal well-being of the woman. By monitoring the maternal well-being, we all know when clients comes in labor, we welcome them, we glance through their books and identify any abnormalities. So we check the labs, the diagnosis aspects. We check the labs, all the labs, whether he has done HIV or a HB are in normal range, hepatitis B in another is that one to also help us to ascertain. Maybe when a woman is resource negative, that one to also help you to ask whether the woman has anti-D or something, or when a woman is hepatitis B positive, that one to you prone to ask whether she has bought a vaccine or something. That will help you after delivery. You can give it to the child or the mother. That one too is helping us to monitor the maternal well-being. And also we check the HB level to know whether it's within the normal range. The HB, we all know below 11.0 is accepted in Ghana. There is a low HB. So you help them. You take sample to the lab and assess the level of the hemoglobin to rule out anemia, so that you are sustained as a midwife, you know the danger ahead. Then you prepare accordingly to prevent PPH. So with the maternal well-being monitoring, you also do your vital signs, you check your BP to know whether the woman BP is in normal range. We know preeclampsia and eclampsia can set in at any time. You check your urine output to ascertain glucose or protein in urine. You check the contractions to know whether the mother has adequate contractions to facilitate labor. You check also you monitor dilatation of the cell, that's the V, so that we know labor is progressing well or not. Then you take the necessary action. So when you get to the fetal well-being, also check fetal heart rate. We all know we check fetal heart rate every 30 minutes to ascertain whether the fetal is very well in neutral. You also check the molding when doing the V. You check the molding when molding is there's a molding there. Then when doing the V, you can ascertain and check for that. So these are some of the maternal and the fetal well-being as a midwife you can do to help really the mother in labor. Thank you.
All right. Thank you very much.
Good evening, sister.
Our time is almost up.
Good evening, sister.
Good evening.
And please, we are about to discuss the pain during postpartum period. Perineal pain. During labor, Tests and episiotomy causes pain to the pregnant mother. And then after pains, we are talking about the contraction of the uterus, which results from breastfeeding of the babies. The breast engorgement occurs when the baby isn't able to suckle well. The breast engorgement will cause a lot of pain to the mother. And then we talk about the cesarean section. After the cesarean section and the anesthesia wears off, the mother would experience most of the pains at the site of the cesarean section. Thank you.
Good evening, sister.
Good evening.
Please, I'm Patience Marfo, and I'm reading on postpartum pain management. First is ice packs and sit bath. So this is a method for managing pain, swelling, and healing in the perineal area, the vagina, delivery, episiotomy, or TED. So down there, there are after bed. And this is applied every 1 hours in the first.
Hey, so who is that?
That to stand to increase blood flow to the area to promote healing, relieve pain, and itching. Talking about the breast care and positioning too, we have to be sure that we wash before breastfeeding. We wash the breast with just water. Avoid soaps we should avoid soaps on the nipple because it keeps the nipple dry and it brings about cracking. And we should feed the baby on demand too, about 8 to 12 times in a day. And as we do this, to prevent engorgement and also wear a fitting bra. Talking about the positioning too, we have to ensure proper fixing and attachment of the baby to breast. And in doing this, we realize that the baby's mouth is wide open, the chin touches the breast, the lower lip is turned, and prevent the deep ventral. Yes, and it also speed up the return of bladder function. And the rest, the last point, paracetamol and NSAID as prescribed. So we as first line analgesics for our individual breastfeeding.
Hello, sister.
Hello.
Hello. Sister, I'm approaching
Hello.
Rosemary. Sister, please, I'm approaching Rosemary.
Okay.
So, sister, please, we are concluding on it. So we are saying that in conclusion, pain is expected, but it is manageable. So, through all this period, through. Hello, sister. Hello, sister.
Yes, I'm here. Hello. It's your network from your end.
Yes, I'm here.
Hello, sister.
Your network. Hello.
Hello, sister. Yeah.
Hello. Can't hear. Hello. Your end is bad.
Hello, Adia.
Rosemary.
Okay. Rosemary.
Sister, please, I'm Rosemary.
Okay. Continue. I'm Prachum.
Hello, sister.
Hello. Hello, Rose.
I think our sister, her network dropped. This is
Yes.
Ophelia. So, in conclusion, we will say that pain is expected to be manageable. And as a midwife, we play a vital role in holistic pain management. And there should be effective control of pain, which improve maternal outcome. Thank you.
Thank you. Welcome. Thank you very much. You have all done well. It's actually neatness. Okay.
Okay, sister.
So good night.
Sister, we are grateful. Bye.
Please, some of us don't have a group. Please. Some of us don't have a group.
You came in late.
Yes, please.
So see your various class friends and then to add you to the groups, okay?
Okay, sister.
Depending on your center.
Okay, sister.
Depending on your tell them. All right. Bye.
Bye. Hey, group 3 people. Next time.